Now moving on to our last section, that is the management of open fractures. It's a very common scenario. Usually the patient has fracture that may be so severe that it's actually the open fracture in such a way that the bone is actually protruding out of the skin and actually is exposed to the outside environment. We will be discussing briefly the initial management, the principles of treatment, debridement, and how to stabilize the fractures actually. And what are the different sequelae of open fractures after the definitive treatment. Now coming to the treatment of open fractures. Initial management, as you know, any management of trauma as per ATLS guidelines. When we come to the musculoskeletal trauma, that usually picked up in form of either it's related with the circulation because there is profound bleeding, or it is related with the musculoskeletal trauma. So has to be ATLS guidelines. You have to go through the same thing. You have to look at the airway, breathing, circulation, and then the disability. Rapid general assessment is required. Step-by-step approach as advised by the ATLS protocols. Then you have to look at the wound. If there is no other associated problems, then the only is isolated musculoskeletal trauma or it's isolated open femur fracture. Then you have to look at the wound. Patient has to be given antibiotics. Tetanus prophylaxis has to be administered, and limb circulation, distal neurological status has to be checked. That is the look, feel, move formula has to be done over here as well. Then we classify the injury. Usually the most common classification is actually the Gustillo classification of open fractures. And it includes 3 types, type 1, 2, and 3. 3 is actually further divided into type 3A, B, and C. Type 1, we call it type 1 when there is a small wound or a puncture wound. There is a clean puncture wound through which bone spike has been protruded. Or there is little or soft tissue damage and no crushing fracture is actually not comminuted. Even if it's a puncture wound and there's a comminuted fracture, this means there's very high energy impact. So actually it's not type 1, it becomes 3A. You have to remember the type 1 are usually small open wounds but with a low energy trauma. Now coming to the type 2. Wound is more than 1 centimeter, it's a little bit bigger wound. There is no skin flap and not much soft tissue damage is there as well. There is no moderate degree of crushing and comminution fractures usually present, but that actually is a high energy impact, and we have to understand that this is what happens. Type 3 is there is a large laceration. Type 3 means a high energy wound with a very large wound. It could be as high as 5 centimeter, 10 centimeter wound. If it's 3A, there will be no basically periosteal stripping of the bone. But if on X-rays we see there's periosteal stripping, that means it goes into 3B, which means extensive damage to skin and underlying soft tissues. You have to look at the neurovascular bundle. If there is a vascular compromise, and for example, there's resulted in the wound has resulted in arterial injury as well, automatically it goes into 3C category. And injury due to high energy transfer to the bone and soft tissue is usually under the type 3 of the Gustillo and Anderson classification. Now coming to the principles of treatment. There are 4 essentials to the treatment. One is the antibiotic prophylaxis, urgent wound and fracture debridement, early definitive wound cover, and stabilization of the fracture. That is how we have to understand that. Antibiotics are very important because there are a lot of dirt and grass and pebbles and whatnot will be coming into the wound, and there will be a lot of microorganisms present over there. We need to go for debridement of the wound, and wound care is important. Then we need to understand if it's a type 3B or 3C injury, if there is massive soft tissue loss as well, how to cover the bone actually. Whether it could be in form of skin graft or could be in form of skin free flaps as well. And then the stabilization of fracture. If it's a segmental fracture, massively comminuted fracture, or there's a bone loss over there, then what to do about the fracture as well. So the first of the 4 is actually the antibiotics. We have to understand, according to the Gustillo, the most common is actually coamoxiclav, which is usually first or second generation of cephalosporin can be given. And usually the important point is they're continued for almost approximately 24 hours. And if you see in the 3A, the problem is as the types increases, because there is actually high energy impact and there is a lot of soft tissue damage, then we associated along with the coamoxiclav, we can give gentamicin or vancomycin as well. And the important point is that this cover continues for almost 3 days. But in case of type 1, we can only do the minimal amount of debridement, and then we can continue antibiotics for 24 hours only. Now the next after antibiotic was the wound care. Now coming to the debridement, operation aims to render wound free from foreign materials of the dead tissue, leaving the clean surgical field and tissue with good blood supply throughout. So you know that we have to wash it properly and thoroughly. If it's type 1, we have to wash it with almost minimum amount of 3 liters of normal saline. If it's type 2, minimum 6 liters of normal saline has to be washed with. And if it's type 3 A, B, or C, then minimum 9 liters of normal saline needs to be used to wash the wound thoroughly. Once we have washed it, we have removed all the foreign material, the dirt, the grass, the pebbles out of it. Then we look at if there's dead tissue, the dead tissue will decay and eventually would be a bed for microorganism. So you need to remove all the dead and devitalized tissue out of it, so that the wound is actually the kind of wound bed is adequate for either the skin or the flap transplantation. Wound excision is done. Wound extension is actually sometimes has to be done as well, so that all the dead and devitalized tissue is removed. Then delivery of the fracture is done out of the wound, and temporary fixation of the basically the bone ends can be done in form of external fixator. Wound cleansing can be done for a lot of normal saline. Copious amount of normal saline can be utilized, and we have to remember that we have to sometimes save the nerves and tendons. But if they are dead, then we may have to take them out. But usually the tendons are preserved because later on these tendons would be important for the muscle function. Now coming to the wound closure. If it is a small uncontaminated wound, it can be closed after debridement, and usually it's sutured. But in more case of more severe injuries, immediate fracture stabilization can be done by use of external fixator, and wound cover is usually either in form of a split skin graft or in form of even free flaps, provided the bed is good for them. But for example, if we have done the debridement, let's say on the day 1 of the surgery, and the bed is not actually adequately prepared for free flap, then what we do is we apply a vac dressing, that is vacuum assisted closure. After 2 to 3 we go for redebridement. We look at this. If the bed is adequate, we either apply skin graft or flap over it, or then we can cover it later on, or we can continue with the vac dressing. So that important point over here is that if you cannot actually expose the bone to the outside environment, if bone exposed to the outside environment would mean it's a dead bone. Temporary stabilization could be in form of either the external fixators or in form of Lazaroff as well. And now coming to how to stabilize the fracture. As I told you, there would be massive comminution, there could be bone loss as well. So the stabilization fracture actually means the most common method is actually use of simple uniplanar or a biplanar external fixator. But sometimes why it's helpful, because it reduces likelihood of infection, recovery of soft tissues, and the method of fixation depends upon actually the degree of comminution, time from injury to operation, and amount of soft tissue damage which has actually occurred as well. Stabilization could be in form of external fixator exchange for internal fixation as long as there is delay to wound cover less than 7 days. We apply the external fixator after debridement, and we apply the vac to the open wound, and we wait for 7 to 10 days. Once the granulation bed has appeared over it, and we know we can apply either the skin graft or the flap over it, then we go for the wound coverage first. And once the wound coverage has been done, then after we remove the external fixator and go for definitive internal fixation of the bone fragments. This could be if wound is contamination is not visible, then we can also stabilize initially with external fixators, because internal fixation with contaminated wound would be disastrous. The nail or plate would definitely get infected and it will not serve our purpose. Then internal external fixation can control the fracture, because once we have wound is covered, we can move from external fixator to the secondary internal fixation as well. Now once we have done this, what is the aftercare? Aftercare is actually the limb is elevated, circulation is carefully washed. We look for the edema, swelling, which may eventually develop compartment syndrome, so we have to look for it. Wound cultures have to be taken if it's not healing properly, but usually If the adequate debridement is done within 7 to 10 days, the bed for the grafting surgery is actually prepared and wound is quite healthy for the coverage. Osteomyelitis from the hospital-derived organism has to be ruled out because Staph aureus is one of the most notorious organisms. Staph aureus osteomyelitis is actually highly lethal. It does not really go away quickly, so you have to be very sure that there is no associated hospital-acquired infection to the patient. And what is the go method to do that? That is meticulous debridement. We may have to go for multiple debridement at times. That we go in first, debride as much as possible, and irrigate it properly, apply back, come out. After 24 to 48 hours, we re-go in again, do all the debridement again, remove all the devitalized tissue which has actually become necrotic or devitalized over 2 days period of time, apply back again and come out. And once after 7 to 10 days, maybe after 2 to 3 debridements, once the bed is properly clean and then the granulation tissue appears, then we can probably go for some kind of either skin graft or flap over it, depending upon the width and the depth of the wound which is present over there. In early appropriate wound closure is important for its coverage. Once the wound is closed, then only we can go for internal fixation. So what is the sequelae to open fractures? Usually the skin results in split thickness skin grafts may be required, areas of contractures may be there as well, and friable skin that breaks down intermittently because there is a lot of skin damage initially at the time of injury, so later on these problems can happen as well. Now what could be to the bones? Usually we have to identify the causal organism which may be causing infection, because at the time with open injuries there is infection is a very common sequelae. So suppression by appropriate antibiotics is necessary, and sometimes we have to go for culture as well so that we give organism specific antibiotics so that the infection can be prevented. And later on it may be result in osteomyelitis. There may be an X-ray evidence of a sequestrum or involucrum may be present as well. Soft tissue flap or external fixator which can be used later on to treatment of the open fractures. External fixators are helpful because they can be used in where this bone is infected. Plate and nail, the problem with them is that it cannot be used in an infected bone. Now, what are the other sequelae to the joints in case of an open fracture? The point is we have to make sure the infection does not penetrate the joint, or there is no arthritis of the joint later on. Debridement and drainage is important, but as the arthritis of the joint is quite painful, so we may have to go for arthrotomies multiple times, irrigation as well, and later on we may have to go for splintage as well of the joint so that they can be kept pain-free as well as infection-free. Stabilization of fracture is of utmost important because if the bone ends will move, they will continue to cause more and more soft tissue problems. So joint has to be splinted in optimum position for ankylosis. So we have to make it sure that we do not actually, sometimes despite all the methods, eventually the pyogenic infection results in bony ankylosis of the joint. So we have to remember that eventually the bony ankylosis can occur as well in case of the joints following open fracture. So coming to the gunshot injuries, the most common open fractures are usually due to the gunshots. This could be the tissue damage is preceded by direct injury to the immediate part of the muscle. This could be contusion of the muscle around the muscle tract. There is a rotation effect such that it leads to problem. And there is a bruising and congestion of the soft tissue as well when the missile penetrates the soft tissue. What is the emergency treatment in this case is actually the first is as when we of any patient, whether it's a gunshot, we have to go through ATLS protocols. If the patient's is airway is intact, cervical spine is good and breathing is normal, then we have to go for circulation. In circulation, the first thing is arrest of bleeding. It could be in form of applying pressure, and it could be applying of tight dressing so that there will be a minimum amount of blood loss. Tourniquet is usually not advised, but if there is frank blood loss which is going on, and probably tourniquet can be applied for some times, but usually it's not a very advisable option. The first and foremost is arrest of bleeding by applying pressure, as you can appreciate it over here. Then is the general resuscitation. As you know, there will be blood loss, patient will be in hypotension, shock, patient would be in hypovolemic shock as well. So we need to give fluids, we need to give blood to the patient so that it resuscitates. And then is at least sterilized dressing can be done initially. Areas then examined for the artery and nerve damage, whether then we go for the identification of tract as well. If there is not massive amount of blood loss and we have controlled bleeding to some extent, then we can look whether what was entry wound, what was the exit wound, how the actually trajectory of the bullet has surpassed, and were there any major nerves and arteries in the path which could have got damaged as well. As it's an open wound, then the principles of those open wound remains the same. That is the antibiotics, debridement, fracture stabilization, which is the utmost important to avoid infection. Then coming to the definitive treatment. That is, definitive treatment is actually exploration of the mesial tract. We have to make it sure that all the dead and revitalized tissue is removed. But there is one problem over here. If the bullet has actually lodged somewhere, suppose even the bullet has lodged somewhere near the joint, but actually is not penetrating the joint, then we do not need to take out the bullet or piece of the bullet out. We need to make it sure that if the patient is vitally stable and the bullet has get lodged somewhere, we can leave it as such. Until unless the bullet has lodged into the joint space. If the bullet is in the joint, then we have to take the bullet out. Then formal debridement has to be done. As it's an open wound, the first and foremost is once the patient has been stabilized, then we have given the antibiotics, then comes the debridement of the wound. Low velocity wounds usually in form of require superficial debridement, splintage of the limb, and antibiotic cover only. And a fracture usually is treated as open fracture. In injury involving soft tissues only, there may be minimum bone splinters. Wound may be safely treated without surgery, and local wound care is only important as well, and with antibiotics. So that is important. If it is has only done soft tissue damage and there is no bony fracture, you have to treat it as simple wounds as we treat the normally, doing some debridement, and we make it sure that all the devitalized tissue is removed and antibiotics are actually given along with the copious irrigation of the wound so that the patient recovers completely. If it's a high energy wound, that is, it was a high energy velocity injury, which means cleansing of wound and debridement so utmost important, because there will be a lot of soft tissue damage. Then excision of deep damaged tissue is important, because there will be the tissue which have actually got damaged now, which eventually become necrotic and dead and would be a breeding ground for the organism. So we have to remove all the deep devitalized tissue as well. Splinting of the facial compartments is important because there will be associated with bony fractures as well. And then we have to fracture stabilization with form of external fixation is done. Then wound is treated for Gustilo 3 injuries, either as 3A, B, or C, depending upon how much of the periosteum splitting is done, whether associated with arterial injury or not. And then external fixation is the way to go for bony stabilization. And in this section, we have briefly gone through the treatment of open reduction. The principles of open fractures is that we give antibiotic coverage because there would be a lot of dirt and debridement and other things which will be going into the wound as well. Then the second thing is most important, is the second pillar of treatment is the antibiotics. After antibiotics it's the debridement. The thorough debridement has to be done. Sometimes we may have to go for multiple debridements and apply vac by the time the wound bed is prepared. The third is actually we have to close the wound. Closing the wound could be in form of skin graft if it's a small wound or a superficial one, and could be in form of free flaps, which if there's a large wound and which may require a complete closure of the wound. And then once we have prepared the bed and closed the wound, then comes the bony fixation. By the time all this is happening, we can apply external fixator to the bone so that the bone ends remain stabilized. Once at 7 to 10 days we have completely covered the wound, we can go from external fixator to the complete secondary internal fixation in form of nail or blade once the infection has settled down. Thank you very much. Keep watching sqadia.com.